Good day, ladies and gentlemen. My name is Dr. Adnan Khan. Here is a brief but comprehensive presentation on health system financing options. What are the various modes of financing, their key features, and why does insurance-based systems stand out the purely tax-based financing models? All people are entitled to quality essential health services without suffering financial hardship to pay for health expenses. This simple but powerful belief undergirds the growing movement towards universal health coverage, now a global commitment under the Sustainable Development Goals. The 17 Sustainable Development Goals adopted by the UNGA consist of targets that primarily focus health. Target 3.8 of SDG 3, that is achieving universal health coverage including financial risk protection, access to quality essential health care services, and access to safe, effective, quality and affordable essential medicines and vaccines for all, is the key to attaining the entire goal, as well as health related targets of other SDGs. Strong financially sustainable health systems create healthy citizens, who can then get the education and skills they need to thrive in a dynamic global economy. Health does indeed produce wealth. Traditionally, healthcare systems have been compared in terms of tax-financed beverage type and contribution-financed Bismarck type alternatives. The world is in the midst of a debate about the relative merits of social health insurance and tax-financed health systems. Most systems are hybrid of the two types, and most have unique caveats embedded within. The basic framework of the health system financing spectrum is defined on the basis of its financing, on delivery, and the access. Before going further, I would like to mention here one of the greatest founders of the idea of a welfare state in recent times. Sir William Henry Beveridge in 1942 produced his greatest achievement, a report looking into the ways that Britain could be totally reconstructed after the war. It is called the Report on Social Insurance and Allied Services. It paved the way for a better Britain. It was this report that identified the 5 giant evils the government should fight, namely want, disease, ignorance, squalor, and idleness. The tax-financed beverage type, as mentioned, named after William Beveridge, the economist and social reformer, it is a model funded by means of general taxation. Responsibility for the budget is in the hands of and under the strong influence of the government. The organization is often part of a pyramid-shaped hierarchical bureaucracy, with primary health care at the bottom and tertiary care teaching hospitals at the top, and are geopolitically organized. Access to specialized care is dependent on a referral from a primary health care, the so-called gatekeeping system. The examples are the United Kingdom, New Zealand, Spain, and Scandinavian countries. Finance is through the public, through the taxes, and it has the universal access. And obviously the delivery is to the public as well. A contribution-financed Bismarck type model, named in the honor of Prussian Chancellor Otto von Bismarck, is funded by the earmark premiums, mainly from salaried population. The system is more loosely organized, with less state influence and more pluralistic, with a strong influence of healthcare providers and insurers. There is often parallel access to primary and specialized care and no strict geographic distribution. Care is provided by the profit or non-profit hospitals and individual practitioners. In this, the most examples are the Germany, France, Netherlands, and Japan. It's a private financing model and it also has the universal access. delivery is through the private health providers. A national health insurance system is a form of Bismarck model and should be seen as a subcategory or variant of that group. While both the national health insurance and the Bismarck models are insurance based, the main difference is that the insurance models are single payer systems as opposed to having multiple payers like the pure Bismarck models, in which the example are the Canada, Taiwan and South Korea. Financing in the national health insurance model could be through the public mode, one of the modes devised by the government. Access is obviously universal and delivery is to the private and at times to the government institutes as well. Most classifications of health systems do not discuss out-of-pocket models as a separate category. However, since the majority of countries in the world are too poor and the governments too weak to institute a public health system of any kind, and as a result they have OOPS, that is the out-of-pocket systems. Most of the countries are the low income and the lower middle income countries. Private financing comes into play, the access is extremely limited and the delivery is also limited to the private sector. No one system is entirely capable of delivering a comprehensive health coverage, and most of the countries build their own models combining different aspects of each. Strictly speaking, the social health insurance and national health insurance frameworks do edge out the others in merits and demerits. Firstly, the contribution financed Bismarck type financing model. Healthcare insurance presents uncountable benefits. Numerous studies in developing and underdeveloped countries have proven its potential. Health insurance reduces catastrophic health expenditures and out-of-pocket payments. It increases utilization of health services and it improves health and well-being. It's a technically feasible and financially viable system, providing equitable health care, stable financing, choice of services, a strong support of the population leading to infrastructure development. Health insurance has a way of mobilizing additional domestic resources for health, allowing organizational change for improved health system, quality and efficiency, which is easier to introduce through purchaser-provider splits and the new provider payment mechanisms. It also extends financial risk protection to more people or provide greater levels of protection to those already with coverage by replacing out-of-pocket spending with some form of prepayment and facilities switching from private health insurance to social insurance. This additional financial protection is seen as a way of allowing more people to use needed services without incurring high out-of-pocket payments, effectively moving closer to universal coverage. The taxed financed beverage type financing model is the next we are going to briefly see. The establishment and performance of tax-based systems depends on what politics makes possible in a particular country. Political instability and sensitivity to political pressure leads to irrational and inefficient decisions. People's expectations of the health services are unrealistic, and underfunding due to small tax base and weaker institutional power affects the healthcare outcomes adversely. The tax-based systems are popularly known as a poor system for poor people. Quality of care and efficiency is challenged with potential inefficiency in healthcare delivery. This primarily results from aging infrastructure, unresponsive staff, inability to downsize or reorient priorities, abuse of monopoly of power, obsolete medical technology is compared with the private sector, and long waiting lists for non-emergency treatments. There is also varied access to medical care and health facilities because of geographical disparity. The tornado of single-payer health care is an essence of a government-run healthcare system. This infographic conveys that a single-payer healthcare system would increase taxes, destroy jobs, make patients wait longer for care, lead to rationing of prescription drugs, and cut funding for the medical research. Now, Bismarck or Beveridge? Well, it's a beauty contest between dinosaurs. The debate is on establishing a system being more towards the Bev-Mark or Bis-Erridge models. The opinion on which system is best can be answered empirically depending on health outcome indicators like overall mortality rate, infant mortality rate, and life expectancy, or healthcare expenditure indicators like healthcare expenditure per capita, healthcare expenditure as percentage of GDP, and the satisfaction with the healthcare system universality. In one of the studies recently published, this figure shows the satisfaction with the healthcare system of the population in the insurance group countries is much higher as compared to the national health system countries. The SSH countries, about 2/3 of the population is very or fairly satisfied with the system, whereas in NHS countries this is the case for only half of the population. Similarly, in one of the studies published in New England Journal of Medicine, the figure shows the sources of healthcare financing according to the country income. On average, almost 50% of healthcare financing in low-income countries comes from out-of-pocket payments, as compared with 30% in middle-income countries and 14% in high-income countries. When payments from general government expenditures, social health insurance that is, and pre-paid private insurance are combined, 38% of healthcare financing in low-income countries is combined in funding pools, which allow the risk of healthcare costs to be shared across population groups, as compared to the approximate 60% in the middle-income countries and 80% in high-income countries. Thus, the key financing issue for low and middle income countries is how to provide increased financial protection for households, that part of the population in the formal sector of employment, in which payroll taxes can be levied, could be included in social insurance arrangements. It is also commonly accepted that the poorest people require complete subsidization for health care from general taxation, and those with low income needs at least partial subsidization. The key question is whether the rest of the population, those who are outside the formal sector of the economy but who are not the very poorest, should be covered by funds raised through general taxation or encouraged to enroll in a contributory insurance program. This challenging and widely points towards a hybrid system tailor-made for a population. There are major differences for higher income and middle or lower income countries for an ideal setup to achieve universality. Now, does Bismarck beats Beveridge? In the one of the reports which are published by the Euro Health Consumer Index 2016, it was very clearly demarcated. The ESI, started as in 2005, is the leading comparison of assessing the performance of national healthcare system in 35 countries. The EHI analyzes national healthcare on 48 indicators, looking into areas just as patient rights and information, access to care, treatment outcomes, range and reach of services, prevention and use of pharmaceuticals, Bismarck systems dominate the top of EHCI ranking as reported in EuroHealth Consumer Index. Beverage systems offer conflicts between loyalty to citizens and loyalty to healthcare system organization. There is a lack of business acumen in beverage systems. Efficiency gains and cutbacks are mostly non-differentiated. Moreover, the Bismarck systems do better than the centrally planned beverage system. Multiple professionals at multiple levels take better decisions and drive development better than the central bodies where incentives driving quality and productivity are essential. Concluding from the previous slide, the index scale is a way to measure to what extent each one of the 35 countries meet expectations of good, consumer-friendly healthcare. This attempt at creating a comparative index for national healthcare systems has confirmed that there is a group of EU member states which all have good healthcare systems seen from the customer or consumer's point of view. EHCI is limited to measuring the consumer friendliness of healthcare systems. The national scores seem to reflect more of national and organizational cultures and attitudes rather than mirroring how large resources a country is spending on healthcare. The cultural streaks have in all likelihood deep historical roots. Turning a large corporation around takes a couple of years. Turning a country around can take decades. Finally, a few quick slides on data collected from Our World in Data to give an idea of the financing healthcare. It's an open source data bank. The global expenditure of healthcare as a share of world income has been increasing steadily but slowly over the course of last couple of decades. In the background, however, there has been substantial cross-country heterogeneity, both in levels and trends. Regionally high-income countries spend and have been spending a much larger share of their income on healthcare than low-income countries, almost twice. Moreover, in contrast to high-income countries, in low and middle-income countries, the public share of healthcare funding is much lower, although it has been catching up and the role of out-of-pocket expenditures is much higher. This is a world map representation of the healthcare financing data. The world map shows the huge differences in average healthcare spending per capita between different countries. In 2013, it ranges from $23.65 international dollars in the Central African Republic to $9,145 international dollars in the USA. The visualization shows estimate of the health insurance coverage across the world. The insurance coverage here includes affiliated members of the health insurance as well as the population having free access to healthcare services provided by the government. As can be seen, all high-income countries have virtually full health insurance coverage, with the notable exception of the US. And similarly, many middle-income countries such as Brazil and China also have very high levels of coverage. In most low-income countries, coverage remains a challenge, but here there are also important exceptions, like Gambia and Rwanda, for example, all have higher health protection coverage than US. Healthcare is one of the most important inputs to produce health, and life expectancy is one of the key measures of population's health. The visualization shows the relationship between life expectancy at birth and healthcare expenditure per capita. As it can be seen, countries with higher expenditure on healthcare per person tend to have higher life expectancy. And looking in the change over time, we see that the countries spend more money on health, life expectancy of the population increases. Similarly, the next visualization presents the relationship between child mortality, measured as the share of children dying before the 5th birthday, and the health expenditure per capita. The ever elusive question of causality is not fully understood or probably addressed, and I would say that the issue of time varying unobservables and potential simultaneity remains. But the presented visualizations are nevertheless indicative of a clear and strong relationship. The health returns to the healthcare investment are substantial, particularly of low-income countries, and indeed these returns, coupled with the returns estimated for conditional cash transfer programs in low-middle income countries, suggest that with current worldwide resources suitably targeted, it could be feasible to drastically reduce world inequality in health outcomes and achieve the so-called grand convergence. There is a debate on the blog, The Conversation, as Global Health Series. Here one can find ample stuff and food for thought on various health financing options. In the end, we'll leave you with a few points to ponder. When it comes to health, your zip code matters more than your genetic code. And I think the biggest problem with healthcare today is not its cost, which is a big problem, but for all that money, it is not an expression of humanity. I would dare to say that there is today enough knowledge to repair failing systems, but is there enough determination? Thanks a lot for your patience. Thank you.